and take it away.
Okay. Thank you very much. Talo for everyone. My name is Baz, uh, Sebastian Paulo. I'm a junior reg in the emergency department at the main hospital in Mototua. I'll be sharing you a few developments and how the pros program is in Samoa. The power of purpose. I'm sure you're wondering what the hell? So I mean, so the power purpose is it's a movement we started a few years ago. It's basically trying to gather or get together a
Oh,
group of people, like-minded people who improve the service and basically, help with our people. And a really good example of that is our pros program. Can you guys all see the?
yeah, we can see.
Yeah. Yes.
Okay, all right. So just before I talk on the our program, the pros, I just wanted to acknowledge a few of our partners who've been supporting our program in the last two years. In 2004, we're blessed to get the funding through from the Australian College of Emergency Medicine through their International Development Fund, which our colleague and friend, Dr. Jonathan, was able to share. And they were able, with this fund, we were able to get four butterfly machines, scans, and four tablets. So it was a huge donation fund through the ASIN. In 2025, we were able to partner up with the WHO office in Samoa, and they were able to fund our program through stationaries as well as catering and some other stuff. Also, would like to acknowledge the Butterfly Network. Yeah, they were not only giving us the butterflies, but we're able to use their cloud where we are able to upload our scans and get coaching from our facilitators, our coaches from New Zealand and Australia.
Mhm.
So thank you to the Butterfly Network for that. We're hoping to continue to maintain that partnership over the coming years. So the pros program started in 2024. I was one of the first cohort. We were blessed to be invited to be part of the pros program. So today's talk is basically a highlight or a summary of how the past two courses have been, 2024, and also to highlight some of the challenges and lessons we've learned over the 2 years, as well as the impact it has been on our practice. Just to give you a context, Samoa is made up of two big islands, Savaii and Upolu, and two small islands in between, Manono and Napolimo. We have uh, only one national referral hospital, which is located in the main island, Upolu, and we have a population of about 216,000 uh, from our last census. So we're a low to medium income country, uh, according to the World Bank, and we just like our Pacific neighbors, we have with our geographic location, we have a lot of challenges. With one national referral hospital, it creates a big access barriers for our rural communities, especially during emergencies such as outbreaks. We have a lot of resource constraints. I can give an example of this. At the moment, we have only two sonographers who are working at the main hospital, working for the whole health system. Only two sonographers. And our CT scan sometimes doesn't work. So with discussion with our early in 2004, we identified there's a need to find a solution to deliver and help our people with all these constraints and resources. Um, so in 2004, sorry, 2024 program, we were able to register, teach 13 doctors, including myself, and these there's 13 from the emergency department, some are from the rural, most are from our rural hospitals, and one or two from the anesthesia department. We had a great number of faculty during our first program, and we had a ratio of about 3 participants per facilitator. And the outcome of that, we had 100% rate through during our 2024 inaugural PROS program. And one of the highlights from that 2024 program was the inclusion of Dr. Micah Misivan, one of our colleagues from PNG. I'm sure some of you might know Micah. He's a wonderful gentleman. He's also a ultrasound fanatic enthusiast who was previously taught the prior, I think 2023, I think he did his POCUS course. So he was identified as one of the champions, and he joined our 2024 Samoa POCUS program and as one of the facilitators, where he taught some of the lectures. So 2024, as mentioned before, we had from the funding from ASIM, we were provided 4 butterfly probes with 4 Samsung tablets. I think this was a massive, as I mentioned before, resources is a major challenge in the Pacific, and with with these 4, it really helped us not only do our training, but we're also disperse these 4 butterflies to one in Upolu, one in the main island, and one at the NKF National Kidney Foundations, where these probes have been put into good use. And we were able to utilize the butterfly cloud. We will upload images, and the faculty are able to assess and provide feedbacks for our participants. Now, after the 2024, me and Dr. Nolan Farmatu had the privilege to be identified as a potential local educators or facilitators. And I think it's a great initiative, and that's what I meant by the power of purpose. I think the pros group really laid the foundation, that really set an example of how courses like this should be taught in the Pacific. A lot of the courses, and the reason why we're not able to sustain these courses is because people fly in, fly out without any, without allowing local buy-in and local ownership. So the pros um, admins and the pros group really set the bar, and a great example for all the courses we're now taking on in our emergency department. So results from our 2024 pros course. So you can see the improvement as you can tell from that graph, the pre-course and post-course assessments with a 100% OSCE passing rate. By 2025, a total of 240 scans were uploaded up in the Butterfly Cloud. And one of the comments from our 2024 course participants, and she said, in a resource-limited country like Samoa, this course is absolutely vital to our everyday practice and will save a lot of time and ultimately save hundreds of lives. Now, I will be sharing you some of the scans we uploaded and um, which I think you'll find interesting. This is the photo of our first pros course. That's myself with on the on your left, wearing blue shirt. Before me is Dr. Angelo. So these were all our first facilitators, our first instructors. Dr. Angelo, next to him is Dr. Michael Strick. He is our Samoa Pros lead, and he's been a fantastic, really humble, very inspiring gentleman to 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 look up to. No, he's been very helpful. Even during his day off, he would call and try to organize focus and make sure pros or machines are taken care of, make sure everybody's uploading scans and so on. Next to her is Dr. Brocati, one of our colleagues, facilitators. And in the middle is Dr. Micah. I'm sure some of you recognize him. Um, Next to her is one of our whānau. She she is Dr. Luana Tanielu. She is the head of emergency department in Middlemore. She was also one of our facilitators during our course. And next to her is Dr. Joe, who's a very enthusiastic gentleman, very good lecturer, and also a friend from Australia. He joined our first course, and he will also be joining this year. And the young man next to him is Dr. Donald. Again, these are all really great people. I'm so thankful and grateful for them for taking their time off their busy schedules, and offering their services to come to Samoa and teach our young doctors. And I think, and even for free, they paid for their own accommodations and travel. So we're very grateful to this group for all they've done for Samoa. These are a few of our photos from the 2024. As you can see, the lady in green, I don't think she needs any introduction. The, the myth, the legend, Joe McCann. So Joe McCann, it was our and still is one of our coaches who always looks after us, who always um, been very instrumental in keeping this momentum going, keeping the pros. I was fortunate last year to be invited to join the ASIM. She's also the president of the Australian Society of Ultrasound Medicine. So a lady with many responsibilities. She wears many hats. But during her busy time, she would always message or check up on us. And, we're very grateful to Joe for all she has done for Samoa. And some more photos of that week. We were also fortunate to have models from our nursing colleagues. They were very um, helpful and offered to provide I think five models during that year for free. So I think I think this is one of the success stories and one of the reasons why POCUS we're able to pick up POCUS very fast and quickly. We do 10 to 15 minutes talks, lectures, and mostly hands-on scans practice. So come last year, 2025, we had a little bit increased number of participants. We had registered 15, we told 15 doctors, with the addition from our pediatrics team. And, we thought we needed to think of ways to make our pros program more sustainable. So we introduced a 100 tala registration fee. We had a bit of back and forth discussions with the group. Someone mentioned that 100 tala might be too much for some people and might discourage people to join POCUS. But actually, we had a different feedback from the group, from the participants. All of them uh, paid 100 tala, and some even paid more than 100 tala just to join the program. And just to give you an idea, I'm not sure if everyone's aware, but I think to do a POCUS course in Australia is about 2 to 3,000 Australian dollars, and that doesn't include the travels and the accommodation. So I think we were very privileged to have this course in Samoa, and that 100 tala fee was accepted by the participants, and they were more than happy to pay. And with the help from the WHO office, we were able to utilize those funds to um, give some stipend for this is the second year of our focus, to give some stipend for our models, and also provide some little gifts, souvenirs for our overseas faculties. And then comes the sad part. We lost one scan. So we're down to three ultrasound scan. One of the scans and the tablet were stolen in the hospital. So that provided another challenge for our group. But we've come up with some ideas, some initiatives. So hopefully we can get some more funding for more scans. And the from after 2025 program, the aim and the vision is to move beyond just the basic focus, and maybe apply some advanced scans, mainly around procedures, which I will be talking about more in a few slides. Again, so in 2025, we did a trainers a short course with our overseas faculty, with Dr. Mike teaching us, introducing us, me and Dr. Nolan, to how to deliver lectures. So me and Dr. Nolan were able to uh, give lectures during the 2025 courses, and help out with the faculty. Um, so some of the results from our 2025 course compared to the 2024, we had as you can see on my right side, the confidence of people doing fast scans went from 0 to 100%. So it was really encouraging to see the consistent knowledge gain and the surge in confidence in our doctors who were in this cohort, and it given us motivation to do more and keep going and try and deliver this annually, and hopefully in the next few years we're able to run our own courses. So this is the photo of our 2025 cohort. We had new facilitators. On the left is Kara, which is she's one of our sonographers. I think I'm not 100% sure, but she was one of our facilitators last year. Next to her is Dr. Nick. and Mike in the middle. And one of our new facilitators last year was Dr. Connor. I think he's from Middlemore as well. Next to them is two of our senior clinicians in Samoa, Dr. Lameko Viali, Dr. Donna Potoi. And the reason we included this was a strategic move. I think a lot of although POCUS is well known to some areas, some parts of the world, but POCUS is very much new to our people, and we wanted to include some of our senior clinicians to advocate and maybe to see the purpose of POCUS and how impactful it is for our doctors, especially those working in the rural areas and in the front line. So, and one of the highlights from this course was Dr. Viali himself. He's a consultant in internal medicine together with Donna. Was what he told us, and he said, out of the 36 years of practice in internal medicine and with his teachers and mentors, one was a renowned cardiologist. No one has given him the probe to scan a patient, to do an echo. But with the young group that we have and the help from our colleagues overseas, is able to learn how to do a basic echo, bedside echo, ultrasound scan. So, this feedback from our group it really, pushes us to push focus to the next level. And I'm very happy that a lot of people are recognizing focus now as part of our, of our, not only um, uh, but also it's a great tool that we can use and at the bedside, and really help our patients out, especially with the resources constraints in our hospital. These are some of the photos during the 2025 course. So you can see there's a lot of enthusiasm, a lot of very focused, very eager participants. And during this year, we used chicken breasts as our model for chicken breast, balloons, and soft drinks to make the models for intravenous to use as models for intravenous access. So very innovative. I think it was Nick's idea to have those models, and you can see people very eager to practice, and they're very happy to do hands-on with the scans. Get more photos. And the on the left side with Connor's photo, we also had the privilege. Were also blessed to have some of the local businesses donating those pull-up banners for our group. They were able to do our pros group with the Butterfly Local, WHO, and the Ministry of Health locals. So, as you may, I'm sure people are familiar now with POCUS. It has helped. It has a lot. It has had a lot of impact, real life impact on our patients. With now the ultrasound available in the rural in Hawaii, our participants are able to pick up and make diagnose people fast and transfer them to where they need to be at the main hospital. And surely I will share those scans. Um, and not only that, but also to help with our system. As I mentioned before, we only have two sonographers, and the CT scan works, shuts down and goes off for a while. So having these ultrasounds at the bedside in the rural really help with those patients, bring emergencies to where they need to be and where they get the care they deserve. And not only that, also we're using ultrasound. Um, People are now, our population are very, a lot of our population have a high prevalence of obesity, and as you can understand, getting IV access is very difficult on our obese patients. So having the ultrasound at the bedside will have helped us to get IV access easier, so patients can receive the treatments that they need. Some of the feedback from our 2025 cohorts, um, comment, quote, in the midst of the dengue outbreak, I can use these skills learned to look for pleural effusion and ascites. Now, we just had recently had the dengue outbreak, and we've uh, we, we've utilized and applied the skills from our pros program on during the outbreak, and a lot of these findings are we can't see it on the X-rays, but using POCUS at the bedside, people were able to pick up pleural effusions, ascites, and help them make the decisions where the patient goes with dispositions, where the patients need admissions, and not only that, to help them with their fluid resuscitations. Another comment from our pediatric colleagues is I can echo to check for pericardial effusion without calling my consultant specifically just for that. As you can see, this focus has helped a lot of people, has given power to people to help improve their practice and lift the standard of care we provide for our patients. And the last comment was monitoring patient progress daily helps me rule in and rule out diagnosis, especially in young pregnant mothers. I think this was a feedback from our obs and gynae colleagues. And as you can see, focus is not only to pick up life-threatening emergencies, but to also monitor patients who are under our care to help us decide whether to escalate or de-escalate treatments. So I think so. These are a few cases. I think some of you have been waiting for this. These are only a few cases we're able to present today. And just to give you a of idea of how we POCUS has been applied and really made a difference for our patients. So this is a 62-year-old male presented with cough fever, pleuritic chest pain, and shortness of breath for about a week. This scan was done by our colleague, Dr. Nolan Fuamatu. So in the upper right corner, you can see the IVC view. You can see there's not a lot of collapsibility with that IVC. The next one, parasternal lung. Again, you can see and those who are familiar with the echoes, there's a large volume of pericardial effusion around the heart, and maybe some RV collapse. And then your full echo chamber view is confirmed that large pericardial effusion. So the vitals for this, he was in shock. So he was treated as sepsis, septic shock. Septic shock versus cardiac tamponade. So Dr. Nolan made the call to inform the surgeons early, and yeah, so surgeons got involved, and for the first time in history, and yeah, the history of the hospital and emergency department. They did a pericardial census within the emergency department. Because unfortunately our OT was busy at the moment. There was no space for him to come up to OT to do the procedure. So they did the procedure in down in our emergency department, ultrasound guided, where they aspirated pus from the pericardial fluid. This gentleman was admitted in the ICU where he received antibiotics, course, and close monitoring. He was discharged, I think, almost 2 weeks later. So this was one of the wins. I think this real life example of how impactful and how focus can really, make a change in someone's life. I think without focus, this gentleman could have probably, have a different outcome. So yes, second case is a female 66 with shortness of breath and beating edema. This is a very common presentation to our setting. She's chronic kidney disease, stage 5, diabetes, and hypertension. That's a scan of the right lung. It shows a massive pleural effusion, and I think that's a foxtail sign. On the left, so the left same lung, um, collapsed lung with a large volume of pleural effusion, and also you can see some B lines in that scan, and also the scan below that, a lot of B lines. So this lady was treated with for fluid overload, pericardial effusion with interstitial syndrome, likely fluid from her CKD. She was referred to medical for acute dialysis. Oh yeah, that's the X-ray of her, mobile X-ray done in emergency, which shows a pleural effusion on the right side with the bat wing appearance, increase markings in perihelic region. Confirmed what we already knew from the scans. This scan was done way before the X-ray machine. Again, it highlights the importance and the role of focus at the bedside. Now, this was an interesting case of mine. Uh, excuse me, a 30-year-old female worsening shortness of breath. Now, to me, I've seen, a lot of these kind of cases in stage. Excuse me. I was thinking like, oh, another fluid overload. Maybe she missed her dialysis. But then I got humbled very quickly, put on a scan, um, got some images, cardiac images. As you can see, um, a massive heart. And with the obvious finding that big pericardial fluid around the heart. Now, this doesn't look. I know this doesn't look like she's in Tambona, but this is not normal, and it raised a lot of suspicion. So we did a few tests for this lady. She came back TB positive. So she underwent TB treatment for a few weeks. I scanned her a few months later, and all that fluid was gone. I think it's our last cardiac case. So this is a 53-year-old female, presented again, worsening shortness of breath for about a week. Same complaint but interestingly different scan findings. So that first color Doppler, not a lot popping up, but maybe it's mild mitral regurgitation. But to be again, oh, yeah, uh, bilateral ventricular failure. But there was something interesting about this case. If you can pick up towards the apex, there's a little thing bouncing there that didn't look normal. So did a few other images, and that again, this is the power of focus. You can do a lot of your views. If one view doesn't give you the answers, you can find the answers in the other view. So I did a subcostal on the left bottom image. You can see that nice round circle hyperechoic uh, mass in the heart, and that's located at the apex, and looks look like it's moving with the contraction. I mean, systolic. So I did a zoom in view, close up view of that mass, and also with the parastatal short. Yeah, we later found out this there's not only one this there's two, it's more than one masses. Big mass in the apex and a small one in the, I don't know if you can see there just below the mitral valve. There's a little mass there bouncing up and down be below the mitral valve. So it raised a lot of suspicion. Interesting. We did a few more tests. Her D dimer came. Top two differentials were is either a clot, multiple clots, or this is a case of metastatic disease. Her D dimer, I think, her D dimer was 5,000. But then again, the dimer can elevate in both. So unfortunately, this case signed out against medical advice. She went home against advice, and she unfortunately passed away a week later. Again, but without these echoes, we wouldn't know what we were dealing with, and we wouldn't be able to pick up these and have a and narrow down on the differentials, and also to give the families and the patients some peace of mind of or some idea of how critically ill they are, and, yeah, to help with decision making. I'm trying to get through these scans as fast as possible. This is a female classic case. It's 22-year-old female, lower abdominal pain, P-test positive. Focus ultrasound within 2 minutes, and that shows free fluid in the right upper quadrant. A quick swipe, longitudinal pelvis. It shows, yeah, free fluid behind the uterus, and some fancy looking, um, not fancy, excuse me, some nice ovarian cysts, bilateral ovarian cysts. It's amazing to me. I mean, I'm a I'm a big fan of ultrasound, if you don't already know. Okay. Next case is a 53-year-old male with abdominal pain, syncytial, coated clammy, in shock. This was his third presentation to the hospital. I saw this gentleman on his third presentation. He looked very unwell, in shock. I no, I didn't think he was going to make it, but we whipped up the scan, did a bedside fast scan, which shows a lot of free fluid above the right upper quadrant, um, and also the pelvis, lower abdomen. An X-ray later that night showed the leaping sign, leaping dolphin sign, which is basically um, pneumoperitoneum. I think it's been there for a while. Now, this case, we had a bit of back and forth tug of war with the surgeons who wanted to push this gentleman to OT as early as possible. But the surgeons on call that night, I wanted to do a formal scan. And I was like, okay. So we did a formal scan and confirmed what we had already seen on the bedside fast scan. So I think this is also a challenge, and I think it's also no, good feedback, not for the patient, but for us. I think we need to involve as many people as possible. We need to spread the word of the focus to as many people as possible. Um, a lot of people don't trust our scans, so but then the patient has to go through, all this to just to get the sonographers who's tired from his 1 in 2 on calls just to tell us what we already know from the bedside. So it's a blessing and also a curse at the same time. Next case is a 13-year-old female male, progressive shortness of breath. This scan was done by our one of our up and coming focus um, fanatic, very um, very hardworking gentleman, Dr. Jared Lameko. So he's been doing a lot of scans. He's one of our top learners. And this, he picked up a very common diagnosis in our setting. So you can see on the first image, the classic hockey stick appearance of the anterior mitral valve leaflet, with some maybe right RA, right atrium a little bit dilated as compared to the left atrium. The middle scan shows and confirms, thick mitral valve. And you throw a little bit of color in it that confirms our suspicion. Shows a moderate to severe mitral regurg. But this gentleman was referred to the person who's doing our formal echoes on island. There's only one who's doing it, and confirmed that this child, the 13-year-old male, has rheumatic heart disease. Another case of rheumatic heart disease. Now, this is a 12-year-old male with a known rheumatic heart disease, but has defaulted his monthly penicillin injections. Presented with chest pains, fevers, and shortness of breath. This scan was done by one of our 2025 participants, Dr. Priscilla Chand. She is a senior pediatrics registrar. She did the scan, bedside echo of this kid in the pediatric ward, which shows very bad mitral valve regurg. And it looks like this kit is now in failure because of the poor compliance to treatment. The next case, another shortness of breath. This is a female, 86, presented with acute confusion, hypothermic, hypotensive, hypoxic. Similar presentations, but interestingly different images, and it is a very common presentation. For me, if I hadn't known about POCUS, someone presented with hypotension, hypothermic, hypoxic, I'd be thinking this lady might be in septic shock, and I'd be pushing a lot of fluid for this lady, which might not be the best idea. Shows very Heart is not moving that much. Severe decreased LV function. Throw some Doppler on it. Moderate, maybe, yeah, moderate to severe aortic regurg and mitral regurg. And with the IVC, yeah, looking plethoric, gotta excuse the probe was moving. But IVC looks like it wouldn't tolerate too much of fluid. So this lady was immediately put on inotrope support with um, high flow nasal oxygen, which really helped with her uh, bring up her blood pressure and hypoxia. She was referred to medical where they continued treatments, and they had time to counsel the family about the prognosis of this lady, which is poor. Next case is a 20-year-old male, again with shortness of breath. He was involved in a motor vehicle accident 2 days prior, where he presented first. It was discussed with the surgical. These X-rays were done, and it was advised to book for an appointment uh, with the orthopedic clinic. Now, the X-ray on the left, chest X-ray, doesn't show much, except maybe the clavicle is fractured. I'm just seeing that now. But nothing popping out from the chest X-ray. The heart looks like it's normal size. Can't see an obvious effusion. Pleural effusion. Nothing in the costophrenic ankles. Yeah, nothing popping out really. The only thing that was obvious was the his X-ray, his right leg. He had a fracture of the femur and femur, tibia and fibula. But then 2 days later, he presented with shortness of breath, and this was during my shift. Now, thinking shortness of breath, I thought, no, maybe another pericardial effusion or another mitral regurg or RHD. But put the scan on the did the on the heart of this patient. Nothing really popped out, and then it made me, you know, think more. So we did more scans on this patient again on the bedside, at the bedside. That's if you can see this, I think this lung, left lung, the lung point. It's not, I started off on the rib, but gotta excuse the if you could excuse the technique. There's a lung point over there. You see the movement here, lung sliding here, and then it doesn't sliding as much on this side. So I thought this guy had a um, pneumothorax. Wasn't tensioning at the moment, but then I continued on with more scans. A right upper quadrant scan showed a massive free fluid around the liver and also in the left upper quadrant. So this guy had massive internal abdominal bleeding with some with a small um, pneumothorax on the left side. So again, the power of focus. A lot of these presentations were similar, but their scan shows absolutely different pathologies. So this is why I'm a big fan of scans. I'm a big advocate for focus to try and get everybody get it, all the doctors involved with focus so they can help identify these patients who need the help and they need further treatments and further investigations, and we need to get these people to where they need to be. So some key insights from the last 2 years, the lessons learned. hands-on scanning, having real-life models available, during the training is very essential to put the theory into practice, and the ratio of instructor to participant. I think that really helped because if we have too many participants per instructor, we can't really help everyone. But with this 3-to-1, or hopefully in the future 1-to-1, will help the instructor, you know, uh, um, find better ways for because everyone has their own way of learning. So we can help identify people who are struggling and find ways to help them, scan better. And during these last two courses, we're able to we found that doing frequent assessments with our participants, we help identify where they need more teaching or they need more hands-on, so we can spend more time with them with the scans. Also, the model we're pushing for POCUS is locally led and locally owned. And I think it's a great model for all the courses in the Pacific. I think that everybody needs to learn from pros and how we're pushing POCUS. Our aim is to run or be able to run our own courses, our POCUS with our local instructors, with a little bit of help from our overseas colleagues. And I think that's the only way we can be able to sustain these courses. Challenges, again, we're now down with three. One got stolen. So we're looking at ways to find more funding to provide more scans. And I think with the limited scans, a lot of people who don't have the scans lose their knowledge, of focus. So I think providing scans for everybody or having as many scans as possible, or maybe we can talk to Butterfly to get some discounts, maybe for our Pacific colleagues, so everybody can own buy their own scans and scanning. The other challenge is we identified is the inconsistent uploads. As you may know from other, is a, and I've been told by Dr. Mike, it's usual for uploads to drop after a few months of the courses, and we don't want that to happen. We want to find ways to 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 address this. We still want people to upload so we can still coach. And it's not only that, but for other people who can access the cloud to learn from the coaching and the interaction. The other challenge is there's a need. There's a need for procedure guided, ultrasound guided training. I think in the future, if uh, if the if time allows and find funding, we'll be able to do more procedure focused ultrasound training, such as putting in CV lines, pericardial senses, and so forth. Now, the last one is the venue logistics. Um, We have a page on social media. It's called the Emergency Medicine in Samoa, and this is where we advocate for our frontline staff. We post up our trainings, whether it's POCUS. We also have another course which we are running, the Emergency Life Support course, and all our simulations we posted on our page. And through this page, a lot of people, a lot of the community have engaged and provided donations. So last year, we were donated after uploading our POCAs and all our trainings photos. Uh, the business community have donated a laptop and a 4,000 Tala projector and also a Wi-Fi router. So this has been it's a blessing throughout this POCUS journey. and the next step is to keep on building from the foundation we've we've laid in 2024, 2025. The next step is repeat the course this year in September. Oh, last slide. Okay. So this is our roadmap. I know it seems very dreamy and man, but dreams are free. You never know until you do it. So 2026, there's an upcoming Pacific Island Society of Emergency Care workshop in August, where I will be leading the POCUS workshop. Uh, I think I don't know why Mike trusted me to run this, but I think he thinks we're ready to run this workshop. Um, and in September, we'll do our annual POCUS course. At the bottom, this is the plan. I think if we want to keep it sustainable, we need to run it every year, twice a year. We need to develop our local faculty. And at the moment, by the end of this year, we are planning to get it accredited by our Samoa qualification authority, so that POCUS can be, recognized nationally as something, maybe to help us to maybe increase their salary or something. And in the end, maybe we can charge them more when they register for another course. I think that's the only way we can keep it. We need to, the long-term goal is we fund our own courses. And not only that, we want to sponsor maybe some faculty from overseas who, or in any way, help them with their, uh, whether it's the airfare or accommodation. That's the long-term goal. And it's also something to give back to our faculty and our instructors from overseas, because they do a lot for us. And coming into Samoa, applying for leave, paying the airfare, accommodation, it means a lot to us. So the long-term goal is to have something, to give back something for them. And then again, our equipment, we want to purchase more scans. The long-term goal is all the rural hospitals should have a scan, so the rotating doctors can use. Future initiatives on the left, I think this is a working idea. We want to include the nursing. And about 90% of our workforce are nurses, midwives, and there's a shortage of doctor. It's almost uh, every year, every month. There's no doctor in those district hospitals. And I had suggested this to the nursing group. I mean, sorry, the pearls group. We need to do like a spin-off obs and gynae emergency course just for the midwives. And that is basically fast scans. And I think that will help and also empower our nurses to join and take up leadership in POCUS. And I think it'll only help the POCUS, maintain this momentum. And, I think it's going to be great. I think we need to do. It is a need. And I think Joe, I know Joe and Louis are cooking up something for this. I have no doubt this is going to be great. The second one is tropical medicine. As you can see, I've gathered some people in high income countries don't see a lot of these scans. This is tropical medicine. This is what we see every day now with the help of POCUS, the power of POCUS. We're able to pick up these. We can teach you guys a little bit of something from the Pacific, let's say. Um, a third is we're planning maybe in the future. We have a high prevalence of rheumatic heart disease, and we also want to do something about do a project on it. And we're hoping, building this local capacity, building the faculty, local faculty. We hope we can branch out to those focus pokers. It's basically the what I said before. We need to do more procedure focus training, and yeah, so forth. We want to expand to the Pacific. We also want to, share with our Pacific and brothers and sisters. We want them to come teach focus in Samoa, and we also want us to come over there, bring also our faculty there, to exchange knowledge, to exchange ideas, and exchange solutions. I understand we all have, we may be in the same blue ocean, but I think every country, experience specific problems that are very specific to their own population, and I think something we can share, and it'll only help our patients. And yeah, research. We want to publish something, some stuff, some of these scans, hopefully in the future. And lastly, equipment. We will find some ways to get some equipment in the future. So next step this year, we have WHO has agreed to sponsor our focus workshop during the PISEC week, which is in August, and also the focus course in September. We're still trying to look for funds for the equipment. We've brought forward, we've given the proposal to WHO, but they said they'll think about it. We're being positive. I am sure WHO will have some money for us soon. By the end of this year, we should be able to formally get accredited by our local SQA for sustainability, and we're hoping to expand this year. We identified Dr. Mike and our senior instructors have identified two new instructors. They are a power couple. They've uploaded some of the scans already. I've showed some of the scans already. Dr. Priscilla and Dr. Papa Ofa, which they will be joining this year's faculty during the workshop and also the course. And that brings me to the final slide of my presentation. I would like to acknowledge the help of our partners, ASIM, WHO, Butterfly, but also to some individuals who taking the time out of their busy schedules, being very selfless. Everybody's busy nowadays, but this group of people, from Joe, Dr. Mike, Dr. Lewis, Dr. Angelo, Joe, um, Bragati, Kara, Donald, and to the pros admins, thank you for all the effort and you put into this work. We're greatly appreciative of all your effort because you're helping us help our people, and then there's something very, you know, remarkable. And we call this the power of, I call this the power of purpose, and so I want to thank you, each one of you, for all your help and all you've done for Samoa. And with that, I'd like to share this. This is the PISEC conference. If you want to join us, if you want to come to Samoa, we would love to host you if you want to join the faculty in August, we'd love to have you and we'd love to host you. So thank you.
Thank you so much, Baz. I really, really like that talk, and I love how you went through so many cases where POCUS actually made a real difference to the patients and even saved lives in some cases, which was really awesome. And I also liked how you highlighted how much POCUS really needs to come into like the forefront of like the minds of specialties because sometimes people in the specialty teams don't really trust our scanning. And I think as you said, it's just a matter of awareness. Um, so yeah, I thought that was great. Do we have any questions? I'll just stop the recording here.